Today's topics of discussion are benign enlargement of the prostate or benign hyperplasia of the prostate, carcinoma of prostate, and stricture urethra. First, we start with benign enlargement of the prostate. We usually written in the book is benign hyperplasia of the prostate, BHP. BHP is the histopathological diagnosis. A clinical diagnosis usually it is BEP, benign enlargement of the prostate. And after histopathological report, the diagnosis is benign hyperplasia of the prostate. First, we discuss about the anatomy of the prostate. The shape is pear-shaped. Weight normal is 7 to 16 gram. It's the size of a walnut. It's composed of 5 lobes. There is the anterior, posterior, and 2 lateral, and 1 median or middle lobe. It having a capsule. The capsule is composed of true capsule and false capsule. The true capsule formed by condensation of the peripheral part of the gland, continuous with the stroma of the gland, and false capsule derived from pelvic fascia. On each side, prostatic venous plexus are embedded in it. Speciality of venous drainage is prostatic venous plexus lies at the neck of the urinary bladder and has valveless communication with vertebral venous plexus, through which, in case of carcinoma of prostate, it spreads. This is a very important point for memorize all the students, because they repeatedly ask in the exam how the cancer of the prostate spreads to the vertebral body or the pelvic bones. It is only that valveless communication causes spread of malignant cells from the prostate to the vertebral venous plexus, and from there they enters into the bones with the emissary veins, and that is spread when the patient become micturate, defecate, or sneezing, coughing, causing intra-abdominal pressure. At that time, the impairment of the venous return through the systemic circulation then goes through this increased venous pressure and blood migrated through the vertebral venous plexus. And at that time, the cells are migrated there. It is very important key point. All students must be remembered. The zones of prostate. The prostate zones of prostate. The prostate is divided into 3 anatomical zones: transitional zone or peri-urethral zones, and central zone and the peripheral zones. These are the transitional zones, these are the central zones, and this is the peripheral zones. So that thing very important is the benign enlargement of the prostate occurs in the transition zones, that around peri-urethral area, and the carcinoma of prostate develops in the peripheral zones. So for that reason, there are 2 things need to know: the site of lesions and pathogenesis of the lesions. The presentation also depends upon the location of the lesion is. For that reason, in case of BEP, the obstructive symptom is more. In case of carcinoma prostate, obstructive symptom is less, until and unless it compresses the periurethral zones, the lately presented with the obstructive symptoms. So benign enlargement of the prostate, it is benign enlargement of prostate which occurs after 50 years, usually between the 60 to 70 years phase, characterized by hyperplasia of the prostatic stromal and epithelial cells in the transitional zone, forms large discrete nodules in the periurethral region, enlarge to compress the urethra, causing partial or complete obstructions. Pathophysiology. Dihydrotestosterone has a major role in BEP. The circulating testosterone is converted to dihydrotestosterone by alpha reductase. The testosterone is released from the testis, Leydig cell of the testis, and converted by 5-alpha reductase. That 5-alpha reductase is localized in the stromal cells of the prostate. Dihydrotestosterone acts in an autocrine fashion on stromal cells and paracrine fashions of epithelial cells and induce growth. In aging men, estrogen level increases, and it is believed that estrogens induce an increase in androgen receptor for dihydrotestosterone actions. So BEP occurs due to synergistic actions of both estrogen and testosterone. So what is the presentations of BEP? For easy memorization, the terminology is very simple term. For the exam, you remember fun. So what fun happening there? The fun is F for frequency, U for urgency, and N for nocturia. These three symptoms can dictate you the patient may develop benign enlarged prostate. So for easy remember, that three things fun, FU1. It is very easy to remember English. So frequency, urgency, and nocturia. But in case of lower urinary tract symptoms, there is two types of symptoms. One is obstructive symptoms, another one is irritative symptoms. Obstructive symptom is hesitance. That means whenever the patient desire of micturition go there, but initially takes time for starting the point. So it is called hesitance. And the straining to pass urine, and more strain there, then that some extent of urine came out. But there is intermittency. That means, look here, there is an enlarged prostate in the median lobe which protrude upwards and go inside the urinary bladder, just like an epiglottis. So initially, whenever the patient desire of maturations, there the median lobe is not more pressure there, so relax, and some urine is passing there. But when the urinary bladder pressure is raised, so the pressure causing the median lobe go down and compress the internal opening, which is causing the intermittency. That means intermittency of the flow. And incomplete bladder empty. Look at things. If the patient having enlarged the prostate causing a post-prostatic pouch formation, because in the urinary bladder at the neck, at the trigone, the epithelium is firmly attached there. So there is a triangular part of the bladder is stressed. And behind the trigone, the mucous bladder wall is loose. So whenever that part is pushed upwards, so behind the trigone there is a pouch formation. So whenever micturate, the bladder is empty, but there is to some extent stay there, remains there. For that reason, the bladder is incomplete, bladder empty. And prolonged micturations. The micturation time in younger individual, whenever the young individual go to the urination, so go and rapidly come back within a few minutes. But in case of elderly patient, those having an enlarged prostate, they go to the toilet, and it takes time. Initially, it takes time to start, and after starting the urination, there is some interruptions, delay. For that reason, there is a prolonged micturations. And after that, there is some post-micturation deepening. So whenever the micturation is finished, The bladder is relaxed. Then again, to some extent, urine enters inside the urethra. Because that enlargement of the prostate median lobe go inside the urinary bladder, which causing the internal sphincter becomes stressed, which is not functioning properly. For that reason, that post-maturation dribbling and urgency is developed, because the internal urethral sphincter lies at the rack of the bladder and external sphincter lies at the verumentanum of the prostate, the urethra. In the urethra, below the prostate, there is a veru. So at the lower end, where the ejaculatory ducts are enters there. So below the verumentanum, there is the external sphincter there between the prostatic part and the bulbous part of the urethra. So external sphincter control the desire of maturation, but early maturation reflex started from. So storage irritated symptoms, increased frequency, urgency, nocturia, and ARD incontinence. Whenever the patient just 1 to 2 drops of urine come in the urethra, so the patient suddenly needs maturation. For that reason, the patient develops ARD incontinence. And another thing is nocturia. So there is a prostatic pus formation there. Urine stay there, some irritation. The bladder mucosa, urethral mucosa is protruded by the protrusion of the median lobe. So the urothelium of the urethra is exposed in the urinary bladder. So that part of the urinary mucosal lining always contact with the urine. For that reason, the patient develops frequency. So these are about LUTS is not specific to PHP. Not everyone with LUTS has BPH, and not everyone with BPH has LUTS. So this is about the presenting symptoms. Some terminology, urgency, it is sudden compelling desire to pass urine which is difficult to postpone. It is called urgency. What about the frequency? It is the complaint by the patient who considers that voids too often during the day. Hesitancy. During maturation, urine flow stops and starts for several times. This is called hesitancy. Incontinence. Inability to hold the urine. What is nocturia? Wake up from sleeping to urinate at night. So what are the changes in the urinary tract due to the benign enlargement of the prostate or hyperplasia of the prostate? So the effect is started from the prostatic urethra and go up, not below the prostatic urethra. There is no changes. All the changes happen from the prostatic urethra to the upwards up to the kidney. So what changed the prostatic urethra? The prostatic urethra, there is an opening in the slit-like opening lies. The direction is the transverse anterior posterior slit. Transverse slit there in the bladder neck. But in case of anterior to the external urinary meatus, the slit is vertical. In the internal opening, just below the internal meatus, transverse, and here it is vertical. So the direction of the urethral internal lumen is slit-like is directed change. That change is required for the natural defense mechanism. What natural defense is? So if there is the same direction from whole urethra, the slit-like opening, there is no pressure mode. If it is a pressure, various direction of the urethra, for that reasons, whenever the urine is passes, the direction is changes. For that reason, whenever the urine is expelled out to the exterior, it comes into a small area. There is no spreading of the urine more. For that reason, that vertical slit of the external meatus is important. Along with that, whenever in the metal stenosis, the metal stenosis is treated by the metoplasty, the shape of the metal opening is changed. So in that cases, most of the patient can complain to you that during maturation, the urine come down and all the clots are swelled up. This is only for the direction of the urethra. So that change direction can creating a more pressure there, and urine can expel out to come in a single point. So this is about the urethral direction, important one. So whenever the prostate is enlarged, the urethra become elongated, more curved, tortuous, and become an anterior posterior slit due to the compression, which causes poor stream, dribbling, and when there is obstruction, it causes retention of urine lately. These are the urethral changes. So that obstruction causing the effect over the urinary bladder. That means for overcome the obstruction, the urinary bladder needs to more contraction, more work. So where there is more work, the muscle of the urinary bladder contracted more times than the normal individual. For that reason, the muscle fiber become hypertrophic. For that reason, there is hypertrophy of the bladder musculature. And that hypertrophy of the bladder musculature causing apart together the muscle fibers, and between that fiber, the bladder mucosa is protruded to some extent, which is called the trabeculation and seculations. That bends over the mucous membrane, looks like a trabeculation. And between the trabeculation, the mucosa is protruded out. In the early stage, it is called the seculation. And whenever the obstruction is not relieved, continuously there is a back pressure. Repeatedly, the obstruction is not overcome. Repeatedly, more work done by the muscles and causing more protrusion of the bladder mucosa to the outside the muscle fiber, then it is called the diverticulations. And posterior prostatic pouch. Whenever the median lobe is enlarged, the bladder neck is high up, and therefore behind the trigone there is a pouch formation, which is called the posterior prostatic pouch formations. And that causing always stay of the urine there, stasis causing invite invasion, and seat of the ultimately needles formation and the stone formation there. And associated with the enlarged median lobe go up, distorted the sphincter, internal sphincter, and that enlargement causing pressure effect also to some extent of the bladder neck compression. All the venous plexus lies in the bladder neck, so that causing the congestion of the bladder mucosa vessels. So elongation, tortuosity, dilatation of the submucosal veins of the urinary bladder. So that is the culprit for bleeding in case of PHP. And stasis causing infection, which causing cystitis. Stasis causing infection, causing the needles formation. Ultimately, the needles can form enlarged formation of the stone formations. So these are the effect of the urinary bladder. Then what about the ureter? So whenever the bladder is not void outward, so it causing the back pressure. The back pressure is migrated through the urinary opening to the ureter. So that causing ureter become dilated, which is called the hydroureter. And that back pressure causing go up to the renal pelvis and calyces, and which causes the dilatation of the ureter and the pelvis and calyces, and ultimately the patient may develop hydronephrotic kidney also. And if it is untreated long time, and the patient may develop end-stage renal failure. It is very lately may develop. So these are about the PHP. Now, for the assessment of the prostatic symptoms, there is a scoring system which is called IPSS. That means International Prostate Scoring System. Is used to assess the severity of the symptoms. This consists a score sheet of obstructive and irritative symptoms mentioned previously. There are some questions that will refer both the obstructive and irritative symptoms, then calculate the scoring and can diagnose what is the severity of the symptoms and what is the mode of the treatment is. But these are more elaborately needed for the postgraduate students. For your undergraduate students, only you just know the name of the terminology is IPSS, that is International Prostate Scoring System. So this is the chart. In the first month, you take the history. First, incomplete emptying. How often have you had the sensation of not emptying your bladder? You ask the question. Then, according to his statement, you score in the chart. And look there, the severity is scored from none to all, 0 to almost always 5. And giving rise to a maximum score is 35. So this is the scoring numbers are setting there. So look, the first thing is incomplete emptying. Take the history. How often have you had the sensation of not emptying the urinary bladder? Less than 1 in 5 times, less than half the time, about half the time, more than half the time, almost always your scores. So this incomplete emptying, frequency, intermittency, urgency, weakness of the stream, straining, nocturia. So then you calculate the scoring, what the score type it is. Then the score calculated. If the IPSS score is 0 to 7, it is mild symptoms. If it is 8 to 19, it is moderate symptoms. If it is 20 to 35, severe symptoms. So these are the scoring systems for assessment of the patient condition and dictate upon there by which we treat the patient according to the scoring. Then what about the examination? The examination is the gold standard treatment is DRE. That terminology previously written in the book is a rectal examination. Now all the things are digital one. For that reason nowadays the terminology is changed to the digital rectal examination. That means put your digit in the rectum, inside the rectum, then you assess what about the status of the prostate is. It is the more authentic examination which is directly by the surgeons. All other investigations are indirect one. It is a direct investigations. Examinations, it is the key point for the digital rectal examination. Must be assessed in case of benign enlargement of the prostate. So by DRE, what are the things we examine? First thing is, it is the size of the prostate. So what size of the prostate you assess? Whenever you put the finger inside the rectum, you can rotate anteriorly. Just in front of the rectum, the prostate is lies. So the posterior wall of the prostate, you can easily palpate their surface is symmetrical, enlargement or not. Symmetrical or asymmetrical. In case of malignancy, there is asymmetrical enlargement seen. For that reason, felt. For that reason, the symmetricity can dictate the most likely it is a benign one. For that reason, size of the prostate you can assess. Symmetric enlargement or not. Surface is smooth or not. Consistency firm. Rectal mucosa free from prostate. Median sulcus become prominent. After removing the finger, you examine the finger. What is there any blood stain or not? That all the things can assess by looking, by doing and DRE. So digital rectal examination is very important in case of PEP, and that examination done in a various position of the patient is. Normally we examine is a left lateral position, but always remember that left lateral position of the patient is the patient lies in the bed obliquely, not the straight. The head on one side of the bed and the buttock is opposite side of the bed, and both hip and knee are flexed. This is very important one. If your head lies on the middle or on near the side of the surgeon, then the buttock is not protruded out. For that reason, the patient lying on the bed, always remember in an oblique fashion, and the buttock put just outside the edge of the bed. So you can easily see the perineum. And before doing the DRE, the first thing is first assess, inspect the perineum. It is very important one. Inspect the perineum, then your position. First thing is the counseling of the patient. One, maintain the privacy. Then you position the patient. Then you ready for doing the DRE. That means you wear the gloves, lubricant ready, and after that, first you introduce the index finger of the right hand directly into the rectum. It is very important one. Never ever directly push the digit directly into the rectum. First, you palpate the anal bulge. So whenever you palpate the anal bulge and lubricate the jelly, there is some accustom the finger with the perineum. So the sphincter of the anal sphincter is not contracted vigorously. If you suddenly press your finger over the sphincter becomes contracted. There is a more need of force to introduce the anus. For that reason, first you lubricate with the finger and jelly around the anus by anal bulge. Then you give a sustained pressure and put the finger inside as far as possible, and limit of the upper limit of the prostate you can easily felt or not, you can assess. Then you rotate right lateral, left lateral, then you rotate the whole body. So that means the whole index finger is rotated and the palm of the finger is directed backwards. So the rectum and backwards whole thing you can assess whole of the rectum also. So this is very important one. And after that, you remove it, the finger, look is there blood stain or not. And after that, you must the jelly removed with the gauze pieces, clean the perineum, and then the clothes are covered and remove the curtain. Then the examination is complete, otherwise not. If you don't remove the jelly from the perineum, after examination, the patient feels become discomfort. For that reason, the cleaning the perineum, it is the job of the student or the doctors who examine the perineum. It is very important one. Then the gloves is put in the bin, the bin which is remains under the bed over there. Don't put in the floor. Be careful about it. In the exam, that thing can examine, all the examiner can see where you put the gloves is. So this is about the digital rectal examination. And other examination includes the examination of the genitourinary systems. So you realize that the lesion inside the perineum, inside the abdominal cavity, but you need to examine the genitourinary system. That means the prostate is related with the bladder and related with the urethra, and it is connected to the testis by the vas deferens. For that reason, examination includes of the like external urethra, meatus, urethra, urinary bladder, kidney, and testis. So the downward examination is needed for your assessment after examination. If the patient need for surgery, then other complication is there or previous any congenital lesion over there or not. Because if the patient having a pinhole meatus or metal stenosis or hypospadias, in that time it is not possible to do the operation like TURP, because their narrow space is narrow, is not negotiated the receptoscope or the ureterus or the cystoscope sheath. For that reason, during examination, you evaluate the whole of the urinary tract. Another important thing is, whenever the patient having an elderly patient, most of the patients are bedridden in their most elderly patient. So when the prostate causing there is a stasis, stasis causing infection. That infection is migrated through the opening of the vas deferens to the testis, and the patient may develop sometimes epididymoarthritis or testicular abscess. So associated with the infection is there or not. For that reason, during examination, you must examine the testis and spermatic cords and the bladder. So be remember about it. In ancient period, in the early period of the surgical life, there is a history that whenever they do the open prostatectomy, always they do the vasectomy, because at that time no coverage antibiotic is available there. So whenever do the prostatic surgery in open one, repeatedly the patient develop testicular infection, abscess or infection. For that reason, for prevention, previously they do the vasectomy along with the prostatic surgery in open surgery. But nowadays, the more antibiotics are discovered and used and easily can prevent infection. For that reason, nowadays we never ever do the vasectomy along with the prostatectomy. So what about the investigations? This is the very important thing. Lot of investigation needed for the surgery, but here I written only for related with the diagnosis. For diagnosis of the benign anal prostate, always remember that the things you investigate, those who are needed, related with the disease. The related the disease is the tract, the disease in the urinary tract. So what is the urinary tract? The main production is excretion thing is urine. So urine examination always needed. For that reason, we do the urine microscopic examination and cultural sensitivity. That cultural sensitivity can dictate you what antibiotic needed at that time. Then ultrasonography of the QB region. So during examination, always in undergraduate, ask the question, what thing written in requisition paper for doing the prostatic enlargement of the suspected patient. So that thing is, you write in the requisition paper, that means ultrasonography of QB region and prostate with MCC and PPR. The terminology is MCC and PPR. MCC is micturating cystometric capacity. That means what is the maximum capacity the capable of the patient to hold urine. The bladder capacity is, it measures. And after voiding, again measure the void which remains into the urinary bladder, which is called the post-void residue. That too indicates the symptoms of the patient and effect of the prostate enlargement. Then another thing is the uroflowmetry. It is also a very important thing, is uroflowmetry. Nowadays, a very popular one. Whenever the patient go to a urologist for the symptom of lower urinary tract, they're writing their uroflowmetry. Go and do a uroflowmetry. But be remember it, uroflowmetry, this test is not more authentic one, because this uroflowmetry done in a toilet setting there is a machine in the floor and the patient on standing and micturate over the container. That container is placed over a sensitive machine. So that machine is connected with a computer, either Bluetooth or a cable one. Whenever the technicians say, go to the toilet and start your micturations. So that starting of the micturations depends upon the individual. If the patient is hesitate, then the patient is ready properly, then the starting is delayed. And if the toilet is then more clean, he is not more comfortably can micturate. So there is a more chance of false impression. And that measurement is not the direct one, it is the indirect one. The flow which over the container, it is reflected back on the sensor below that container, and which is measured directly with the computer, indirect one, not direct one, indirect one. For that reason, that uroflowmetry is not always correct. And another thing is, it is very important thing is the transrectal ultrasonography. Normally, we can assess the urinary system by ultrasonography in the superficial probe or the lower abdomen. Superficial probe, abdominal probe with the lower abdomen. Place the probe over the lower abdomen or the back, then can see the bladder, prostate, etc. But good picture can assess by doing the ultrasonography with a transrectal probe. That means this is a probe which enters inside the rectum. Over the probe, put a condom for prevention of fecal matter contamination of the probes, and place just like a DRE. Just put inside the rectum with lubrication. Then the probe is direct contact with the anterior wall with the prostate, and the image given in the computer, they can see directly the homogeneity of the prostate, length of the prostate, breadth of the prostate, and the anteroposterior diameter can easily measured. It is more authentic to assess the prostatic enlargement by transrectal ultrasonography. Sometimes asked in the exam, and what is the transrectal, which position, which method is best for the prostatic enlargement diagnosis ultrasonography? His answer is transrectal ultrasonography. Next one is serum PSA, prostate specific antigen. This is a very important marker. That means it is needed to evaluate the patient having a carcinoma of prostate or not, or a baseline investigations is needed to do an PSA. That IVU. Nowadays, IVU is not needed all the time for diagnosis of BHP. It is needed to see the renal function, anatomical delineation. For that reason, nowadays very, very rarely can done it. Easily no need. The ultrasonography, serum creatinine, other investigation can easily assess the renal function. So if there is no hydroelectrolysis, no need to do an IVU. Only do the ultrasonography and the electron investigation can easily diagnose the BHP. The renal function needed some other investigations, which is others renal function tests like serum creatinine, urea, electrolyte, etc. But this is the MCC. That means usually 400 to 600 ml is the volume that the bladder musculature can tolerate before the patient experiences strong, uncontrollable desire to urinate. What is PBR? Amount of urine left in the bladder after urination. And usually less than 50 ml is considered for normal, and volume greater than 100 ml is generally considered abnormal. Ultrasonography for BPH or BHP, formula to measure the volume. Multiplying the largest anteroposterior height, transverse width, cephalocaudal length, prostate diameter by 0.524 is probably the most commonly used method, since it is rapid, reproducible, has been shown to have a high correlation with actual prostatic volume. This is the formula to measure the volume. So look, there is a, whenever the prostate is enlarged, the median lobe is pushed inside the urinary bladder. Just like in epiglottis, there is a protrusion there. And one thing it is, look, there is the surface epithelium is smooth in outlines. In case of bladder tumor, there is an irregular one, usually on the lateral side, seen in case of bladder tumor. And my surface is irregular, but here the outline is smooth in outline. So by seeing the picture, you can easily confirm that give your opinion that it is a benign enlargement, most likely. So this is about the uroflowmetry, is the electronic recording of the urinary flow rate throughout the course of micturations. The results of uroflowmetry are known specific for the cause of the symptoms. For proper uroflow test, voided volume should be at least 150 ml. That means if the patient is void only 50 ml, the recording is not complete one. So the voided volume must be at least 150 ml. Otherwise, the test is not accurate one. That thing must be remembered. Sometimes some individuals cannot micturate 50 ml, more than 100 ml, 50 ml. In that cases, uroflowmetry is not conclusive one. It is an important factor. Next thing is points to be noted in uroflowmetry. What thing you see in the uroflowmetry? Maximum flow rate. Maximum flow. So this is the maximum flow measurement, and average flow rate, the calculation in the chart below, and voiding time, from when started, from when it is ended, voiding volume and pattern of voiding curve. If the patient is hesitancy, there is zigzag manner which curve is. So by looking the uroflowmetry, you can assess to some extent of the same diagnosis of the disease. With properly performed uroflow test, normal flow rate in male is about 20 to 25 ml per second. Normal flow rate in female, 25 to 30 ml per second. Be remembering, in case of female, the urethra is more spacious, and more flow of urine there. The obstruction should be suspected when maximum flow rate is less than 15 ml per second. Less than 15 ml per second. So look the curvature. One, this is the normal one. Go rapidly micturate and ending there. And in case of benign prostate, there is a slow to start, go to the P, a long time to micturate. In case of urethral stricture, the flow is a long time, but the flow is the more. The flow big is not more, less in amount, maximum. So these are the chart can dictates you what is the disease is. So what about the symptom? The treatment. The treatment is depends upon the symptoms. So according to the IPS score, it is 0 to 7. It is mild symptom, watchful waiting. If it is a moderate one, 8 to 19 scores medical therapy. If it is severe symptoms, 20 to 35, go for surgery. So all the BHP are not treated by surgical one. Be remember about it. It depends upon the symptom of the patient. It is the main thing it is. The enlargement of the prostate is most of the individual in the elderly patient. But all the patients don't need all the time to surgery. This surgery is a very limited one. Nowadays, more drugs are available in the market. The surgical treatment of the prostate, it become declining. No need of surgery in all the time. Next. So, watchful waiting. What thing you wait? What thing you watch? That means no bothersome symptoms. You ask the patient what the symptom is. Not significant obstructions. No need to treatment, surgical treatment or medical treatment. The severity and distress due to the symptoms may be improved through simple measures like decreased fluid intake, especially prior to bedtime. It is a very important one. In case of enlargement of the prostate, always prescribe the patient. Don't take much amount of fluid, particularly at bedtime. That means after 9 p.m., less amount of fluid can intake. So at the bedtime, there is a less symptom, less nocturnal symptoms. Patients should be observed for bothering symptoms and development of significant obstructions. What about the medical treatment? Nowadays, the medical treatment is, there is alpha receptor blockers. That alpha receptor blockers having two types. One is selective one, another one is non-selective one. Previously, we prescribed the non-selective one, phenoxybenjamin, luminipress, but nowadays we don't prescribe it. Nowadays, more selective one, alpha receptor blockers, it is tamsulosin, we prescribe it. because in case of prazosin or phenoxybenzamin, it causes the more postural hypertension and it causes the more systemic effect. But in case of alpha-1 selective blockers, there is a less generalized symptoms. It is less general effect, selective effect. For that reason, we choose the tamsulosin. That means the mechanism of action is they act by blocking the alpha receptor in the prostatic smooth muscle, and therefore leads to relaxation of the prostatic smooth muscle. If the prostatic smooth muscle is relaxed, so the compression effect of the urethra is declining, the patient can improve the flow of urine. So with that hope, we prescribe this tamsulosin. The another one is the finasteride, 5-alpha reductase inhibitors. That means that 5-alpha reductase inhibitors is a finasteride or dutasteride. The mechanism of action is it blocks the alpha reductase inhibitase enzyme and inhibit the conversion of testosterone to diethyl testosterone. So if diethyl testosterone conversion is cut off, so the prostatic muscles glands are enlarged less. There is a less symptoms, decrease the size to some extent, less symptoms. But before prescribing this 5-alpha reductase inhibitors, always do the PSA. If PSA is normal, then you can prescribe. If PSA is high, never ever prescribe the alpha reductase inhibitors. So what about the surgical options? Lot of surgical options available in the world. But for your undergraduate level, you only remember only one thing is, it is surgical, minimal invasive surgical treatment is TURP. It is sufficient to pass the examination. That means transurethral resection of prostate. That terminology is sufficient to pass for examination. Other terminology no need to know for the level of undergraduate levels. But that thing you know, because the world is more faster, more advanced treatments are given there, more easily recovered, less morbidity, are only the expense of money. Because more sophisticated the treatment, more expensive the money one. So this is the treatment options. So endoscopic methods usually is TURP. Another one is TULIP and TUPP. TURP means transurethral resection of the prostate. TULIP means transurethral laser-induced prostatectomy. That means introduce the holmium lasers through the cystoscope. The holmium lasers is placed over the prostatic tissues. That holmium lasers can separate dissect the enlarged gland and subsequently dissection the enlarged part from the normal part and push the glandular tissue and go inside the urinary bladder. And after pushing inside the bladder, the whole of the gland, enlarged gland, is removed with the morcellity by piecemeal. So it is more sophisticated one, less bleeding, and more precise surgery done. And another important one nowadays, it is also in future maybe more popular in future maybe, which is transurethral vaporization of the prostate. The prostate is vaporized by giving some energy. The prostatic tissue becomes vaporized. There is a channel is enlarged. The patient can be cured subsequently. So our gold standard treatment nowadays is bipolar saline TURP is the gold standard treatment nowadays. Bipolar saline TURP. It is a gold standard treatment. So later I will describe what the bipolar and unipolar, monopolar saline TURP, bipolar, monopolar TURP and bipolar saline TURP. We can discuss later. What about the open methods? The open methods nowadays almost obsolete one. But in the exam, most of the examiners, they are more familiar with the previous, knowing the terminology. For that reason, always remember that three things are open methods is retropubic prostatectomy, transvesical prostatectomy, and perineal approach or perineal prostatectomy. The prostatectomy means not the whole prostate is removed, only only the enlarged glandular part is removed. So the open technique needs to place your hand, put your finger inside the abdomen, and the prostatic tissue is divided and remove it out. For that reason, the approaching mode is the name is. So whenever you approach through the retropubic approach, that means give a fenestral incisions, the skin subperitoneal tissues are divided, rectal sheath is divided, then the rectus muscles and pyramidaries are retracted, the bladder is full, and in that case is retraction done, and subsequently retract the bladder, go dissection into the retropubic area, and ultimately go into the anterior wall of the prostate, make an incisions, then the prostate is dissected out, and gave some stitches there, put a catheter inside. This is called the retropubic prostatectomy. In case of transvesical one, this approach is similar up to the opening the retropubic space. You don't go through the posterior wall of the capsule. You just open the urinary bladder, through the urinary bladder, go inside the prostatic urethra, and put your index finger. And by the index finger, you fracture the anterior commissure of the prostate. Then rotate your finger between the normal prostatic remaining tissue peripheral part and the enlarged part. Make a cleavage. All the things of the enlarged prostate is remove it out. Then the bleeding vessels at the neck are stitches, 4-point stitches there. Put a catheter in the 3-way Foley catheter place there, and the balloon is inflated, push it and make a traction in exterior. So that traction causing the bladder neck compression, and it causes the hemostasis, and ultimately you close the bladder and remove it. Put a drain in the subperitoneal tissues, then close them. And this is approach about the retropubic and transvesical approach. And perineal approach is the Young's procedure. The perineal is very, very rare. It is not done. There are two methods previously more familiar. Open surgery, one retropubic prostatectomy and transvesical. So for the examination, some question asks what are the name of the open surgery or the prostatectomy are. Then your answer is retropubic prostatectomy or transvesical prostatectomy. So what about the indication of the TURP? The enlargement of the prostate happened in all the age groups. So all the patients don't need surgery. So whenever the indications, this is calculated by the IPS score. And another one is you look the symptoms and the diagnosis. That means some complications. That means absolute indication. Whenever that enlargement causing acute retention of urine, the patient is not capable to void urine. So in that cases, the patient must be needed to do the surgery. Then chronic retention with renal impairment. There is a chronic obstruction there, so that causing chronic obstruction there that causing some neurogenic manifestations, like the patient does not have any impairment, and ultimately there is a bacterial change, hydronephrosis. In that case, you must do the prostatic surgery. And another was a broader outflow obstruction with complication. That complication is R. So there is an obstruction causing stasis causes infection. So repeated urinary tract infections. So that infection is due to the stasis. That means whenever the postbiotic urine is more, there is more chance of infection and causing the UTI. The other are recurrent gross hematuria. Some vesical piles, their enlargement due to the pressure effect. There is more pressure in the bladder neck and causing the engorgement of the vein and causing some repeated bleeding there. So in that case, you must need to relieve the obstructions. Sometimes the patient, that obstruction for overcome, the patient needs to more work the urinary bladder, causing some diverticula. So diverticula, again, there is the causes of stone formation, infection, etc. For that reason, you must do the surgery. And whenever the patient having stone formation due to the enlargement of the prostate obstruction, that cases must be do the surgery. So relative indication is when the symptom, sometimes the patient having the prostate is not too much large, but they're having a more irritating symptoms. In that cases, the IPS symptom is more than 20, you do the surgery. When the medical treatment failed, and when the maximum flow is less than 10 ml per second, not only the maximum flow, you also correlate the other symptom of the patient is. And if the patient is repeated, there is a repeated PBR, postgraduate residue is more than 100 mm. Then usually go for the surgical treatment like TURP. What about the pre-operative counseling? This is very important thing is. So you do the surgery for relieving the symptoms. So that whenever you relieve the symptoms, that means relieve the obstructions, that causing some other symptom develops, which are not due to the prostate, which are due to the surgical deformity. The deformity is you do the TURP, that means the medial lobe of the prostate is enlarged. So whenever we do the TURP, the inner urethral lining up to the verumentanum, along with the prostatic epithelium, along with the bladder neck, we can dissect it by any means, either open or surgical, open or endoscopic manner or laser manner. So in that times, the internal sphincter become damaged. So that internal sphincter function, you must remember. What is the function of the internal sphincter is? It is maintain the continence one. Another one is, it is very important thing is, during ejaculation, the seminal vesicle and prostate, that means seminal vesicle and testis, all the seminal fluid and semens are migrated into the prostatic urethra, which is propelled forward, go to the exterior due to the constriction of the internal sphincter. So during ejaculation, the internal sphincter is closed, so the semens is ejected forwards and go to the exterior, and subsequently the patient having a child or offspring there. So if you do the TURP or open prostatic surgery, at that time the internal sphincter becomes damaged. So the patient, if he wants a offspring subsequently of the TURP, it is not capable because the semen is not expelled out anteriorly. It goes into the retrogradely to the urinary bladder. So sometimes in the exam, if the elderly patient, he having a development of retention of urine, prostatic enlargement, needs to surgery, but after surgery, he demanded an offspring subsequently. How can it possible? It can possible by doing some measure that whenever the ejaculation is go to the urinary bladder, collect the urine, centrifuge the semen content, then from there you collect the semen sperm and go for artificial inseminations. This is the technique for after doing PHP, if one body can do an offspring subsequently. What about the erectile dysfunction? This is an important one. You do the surgery, there is some nerve damage maybe due to the medial diathermy, which causing some erectile dysfunctions. There is the risk of reoperation. Reoperation means sometimes you do the TURP, during TURP, the tissue is cut from the neck to the veru. So at that time, whenever you remove it out after doing the surgery, during surgery you do continuous irrigation at the surgical time, so tissue is compressed to outwards. So you look, there is enough space so the patient can capable of maturation, you think. But after removing the surgery, remove the cystoscope, the hanging tissue to some extent may projected inside the lumen, and during maturation, that fragment of the mucosal lining, prostatic tissue, block the urethra and sometimes needed to reoperation. For that, the risk of reoperation can easily done. You consented. Pre-operative counseling needed. And post-operative morbidity like UTI. So, whenever delineate the tract, urinary tract from the exterior, previous there is infection or post-operative there is infection, anytime can develop. Another important thing is incontinence. It is very important one. You must counsel the individual. If incontinence develop after TURP, the hell of the patient life, because it is very difficult to manage. The patient's life can very miserable. For that reason, to some extent, can develop. May not. If you're a good surgeon, if you have enough knowledge, if you do a precise diathermy, and if you do, never ever go down to the barumentinum. If you had a resection done below the barumentinum, there is every possibility to damage the external urinary sphincter. In that time, there is a more chance of incontinence. And another thing is hematuria. It is a very common complications of TURP because most of the surgery except urinary tract, we can almost 90 to 100% hemostasis after completion of the surgery. But it is the only surgery where you always remaining there to some extent of bleeding during completion of surgery. There. Always, because to some extent capillary there, small vessels there, which can subsequently hemostasis, but sometimes bleeds there. So for that reason, hematuria, pre-operative counseling must be done. And another one is dribbling, because the external sphincter only maintain the continence. There is no internal sphincters. So sometimes the patient may develop dribbling, etc. What about the complications of TURP? Pre-operative complications, para-operative complications. This is the very important one. So the TURP, during TURP operations, the patient under spinal anesthesia. Usually no need of general anesthesia. Usually done with the spinal or epidural anesthesia. So during spinal anesthesia, the patient giving some fluid pre-operatively for spinal anesthesia, loading fluid there. One. Second thing is, whenever do the surgery TURP, there is a monopolar diathermy used and bipolar diathermy used. In case of monopolar diathermy, whenever you used the cutting the tissue under the water, it is important thing one. So during placing the cystoscope or receptoscope, there is continuous irrigation of the fluid inside the urinary bladder. So through the water, within the water, the tissue is cut by the diathermy. So whenever a monopolar diathermy used during resections, the water must not having electrolyte containing fluids. Must not, never ever. If it is electrolyte containing fluid, the current is not focused in a central point. The current is dispersed surrounding the tissues, which is not over the loops. So if don't work over the loops properly, don't cut the tissue. So for that reasons, during TURP, in unipolar diathermy used, there is a fluid, irrigation fluid used, which is 1.5% glycine. 1.5% glycine concentration fluid is chosen for TURP. It is during exam that question is asked. Which fluid is used for the TURP? If somebody asks in the monopolar diathermy used, somebody may not ask. Your answer is, for the common general, is glycine, 1.5% glycine. Why use the glycine? Because it is non-electrolyte containing fluid and it is an isotonic fluid. It is an isotonic fluid. Another important thing is, whenever the TURP done, during that time, there is irrigation is given from about 2 to 3 feet height from the chamber of the bottle. So there is a pressure effect, the fluid over the urethra. So whenever you cut the tissues of the epithelium, then the vessels are exposed there. So for the high pressure, to some extent the fluid is absorbed through the venous system to the circulation. So that is causing the volume overload of the elderly patient. So elderly patient, the cardiac start is compromised. Whenever there is a volume overload, the patient develops respiratory distress. The patient may develop heart failure. For that reason, it is called the TURP syndrome. TURP syndrome. And during the surgery of the TURP, what amount of fluid measured by the assistant And sometimes during the surgeon asks how many bag of saline glycine used. That asks, this is about the time of the surgery. If long time surgery is done, there is a more chance of water absorption. If it is short time operation done, the less amount of fluid is absorbed. So be careful about the operation time and the volume of irrigation of the fluids, which is monitored by the anesthesiologist, because the anesthesiologist take the measure what the patient having respiratory distress or not, take the saturation by seeing the pulse oximeter. But in case of bipolar saline TRP, the important thing it is, the current is passes from the one loop to other loops. Don't need any earthing plate. So there is no chance of current dispersed throughout the whole bladder. For that reasons, in case of bipolar saline TRP, electrolyte containing fluid can easily used. So in case of bipolar saline TRP, we used the irrigation fluid normal saline. So normal saline isolated fluid having a less chance of TRP syndrome. Then the other thing is the excessive bleeding. So when there is excessive bleeding, the field become dirty. It's not properly seeing the lumen. It's not properly doing the surgery. Then the complication is perforation of the capsule. If the surgeon are not expert enough, if cut tissue, so more deeper, ultimately the capsule become ruptured. Usually happen anteriorly, because the anterior prostate tissue are smaller in amounts. So be careful about the anterior part of the prostate sections. So there is more chance of perforations. And whenever the capsule is perforated, so the urine and the fluid are expelled out from the prostate to the retropubic space. And sometimes if the surgeon is not expert enough, if the knowledge is poor, if the surgeon is rough, if the field is dirty, in that time there is another chance to injury to the urinary bladder, because the receptoscope sheath and the loop, if you push and go inside the bladder and touches the diathermy, may cause perforating the bladder. For that, be cautious about using the diathermy, using the loop. Be gentle. Then there is a less chance of bladder perforation in triangle injury. And another one is external injury to the external sphincter and the urethra. That two things also depends upon the expertise of the surgeon and the smooth handling of the surgeon. If there's gentle, negotiate the receptoscope, there is a less chance of urethral injury. If your knowledge is enough, you don't go down to the peromentinum, there is a less chance of injury to the external sphincter. So these are the complications needed to detect per-operatively. Otherwise, it is very difficult to manage post-operatively. So be cautious about, be gentle, smooth, and very humble to treat the patient during the TUR. The other complications are the post-operative complications. That thing it is post-operative complication, that is reactionary hemorrhage and clot retention. These two things very close to each other. That means after doing surgery, you place a catheter, come back, send the patient to the postoperative ward. There is always some bleeding there. So that bleeding is marked. If there is more marked, then there is a chance of clot retention. So that hemorrhage, to some extent there, which is not stay inside the bladder, because whenever to send the patient to the postoperative ward, place a catheter, it is a 3-way Foley catheter. We remember it is. Normally in the ward, whenever a patient retention of urine, we put a catheter, the name of the catheter is 2-way Foley catheter. Somebody says the bi-channel. Basically in the book, it is not the bi-channel, it is a 2-way and 3-way catheter. The 2-way catheter is done all other individual except the prostatic or bladder surgery. Where there is a chance of bleeding, always put a three-way catheter. One thing. Second thing is, always monitor the patient post-operative period. Otherwise, that reactionary hemorrhage, more amount is there, don't void outside, so that is become clotted there. Whenever the blood becomes clotted, the catheter is not functioning. For that reason, for prevention of clot formation, always we continuously irrigate the urinary bladder with the Foley catheter. That Foley catheter is a three-way, one way for the urine passes, one way for the inflation of the balloon, and another way is to pass to irrigate the irrigation fluid, normal saline, through the catheter to the urinary bladder. So if you always irrigate the fluid there, so there is a turbulence in the fluid. For that reason, blood is, whenever there is oozing or bleeding, the blood mixed with the irrigation fluid and urine come down through the catheter urine pathway and urine back pathway and go to the exterior. We remember it. And another thing is, for the prevention of bleeding, always we put some traction of the catheter in the posterior surgery over the thigh. So that traction causing the balloon is inflated at the neck of the urinary bladder, compression over the neck, and over the neck there is a venous plexus which compressed, there is a hemostasis to some extent. And after a few hours, 6 to 8 hours, whenever you release some traction, then there is less bleeding there. And at the same time, I also discuss about the management of the reactionary hemorrhage. The reactionary is managed by irrigation only, sufficient, nothing else, nothing needed. This irrigation channel is open more and more fluid is irrigated, there is less chance of clot formation. If there is a clot formation, it is very difficult to manage conservatively. Sometimes needed to send the patient again the operation theater, introduce the cystoscope, clot are evacuated by the Helix evacuator, and again to some extent of hemostasis with the diathermy. Then again put a catheter and manage it. And parallelly, the patient needs blood transfusion. Be careful about it. Then about the UTI. So UTI, urinary tract, is a dirty channel. That means those channel which is connected with the exterior, there is chance of infection. So that patient having obstruction, so there is a stasis there is infection previously pre-operative also. For that reason, cultural sensitivity can treat the patient properly for operative and post-operatively. According to the sensitivity, you prescribe the medications. But in the exam, repeatedly ask a question. Tell me some name of the drugs which we prescribe for urinary tract infections. Name some drugs like quinone derivatives, that means ciprofloxacin, levofloxacin, and some aminoglycosides, gentamicin, amikacin. That things must be remembered. Sometime asked in the exam. What about the sepsis? This is a very important thing. Is whenever the sepsis develops, the patient having fever, systemic manifestation there, so treat the patient vigorously with antibiotics and monitor the patients. Otherwise, the patient may die because most of the patients are vulnerable. These are the elderly age group of patients. And about the epididymoarchitis, that means don't ignore the testes. Whenever you treat the patient or doing the surgery of the prostate 1, always in the post-operative period, look about if the patient complains any pain in the testes or scrotum. You look and palpate there. Is there any tenderness or not? If there is a tenderness, you must remember that there is a chance of infection. The antibiotics which you prescribe is not properly accepted there. For that reason, you must change the antibiotics. And another one is stricture urethra. That stricture is not previously present. That stricture is developed by the surgeon. because if the surgery is rough, there is a less lubricant introduced during the operations. Roughly handle the urethral mucosa, they injury the urethral mucosa, subsequently it becomes seen as a stricture develops. For that reason, it can easily compensated, easily negotiated. If you do the gentle manipulation of the urethra, there is a less chance of stricture urethra. If there is a stricture urethra develops, needed to treat the stricture subsequently. And another one is bladder neck contraction. It is one of the complications. After a few years, sometimes the patient presents with the retention. That means the bladder neck, there is a scarring and bladder neck become narrowed and contraction develops. So in that type of patient may need some again operation to release the contracture by doing an BNI, bladder neck incision. Bladder neck incision. The other complications are retrograde ejaculation, urinary incontinence. That two things are already discussed previously. What about the indication and contraindication of open prostatectomy? These are all the previous conception. Nowadays, whatever the size, there is no contraindication to do the endoscopic surgery, because you don't need to remove the whole prostate. Your aim to make a passage by which patient can passing the urine and continue the life. So with that hope, no need of open surgery nowadays. These are the old conceptions. So these old theories are indication large prostate more than 100 grams, always go for open surgery. These are the old conceptions. Concomitant bladder condition that requires such as symptomatic bladder diabetic lump, large heart calculus that cannot be managed transurethral. Large heart calculus, it is one of the indication for. So in that cases, you can do it. You do the TURP along with just open and remove the prostate, remove the stone. No need to the open prostatectomy. Do the prostatectomy by endoscopic and bladder is removed with the open method. So both the method can done simultaneously. So what about the contraindication? There is small fibrous prostate gland. It is also nowadays no contraindication. It's previous one. Previous prostatectomy, it is also not a contraindication. Previous pelvic surgery. These are the contraindication. Previous prostatectomy. So don't go for the open prostatectomy again. Contraindicated, it is contraindicated. Nowadays all the open endoscopic one. And previous pelvic surgery. So open prostatectomy don't go. Any type of prostate cancer. So never ever go for the open prostatectomy in case of prostatic cancer. So irrigation fluid used for the TURP, ideally the irrigation solution should be, it is isotonic, electrically inert, non-toxic, transparent, non-hemolytic, non-metabolized. These are the things, remember, for use the irrigation fluids. Now,
your doctor has recommended you undergo a transurethral resection of the prostate, or TURP. But what does that actually mean? TURP is designed to relieve symptoms by reducing the size of the prostate. It is also a diagnostic procedure. Tissue removed during a resection of the prostate.
So this is the resistoscope sheath. This is the resistoscope sheath. This is called the working channel. There is a telescope. Over the telescope, the camera is attached, and here the light source is attached. So through the light source, the light is illuminated there, and there is a lens there. Through the lens, the image is transferred to the monitor. So this is the telescope. This is the light channel, and this is the working element, and this is the resectoscope sheet. The total instrument is named the resectoscope. Resectoscope. The tissue is for resection, but that is the name is resectoscope. And look there is a loop. So whenever the handle is compressed, the loop is go out. Whenever the handle is released, the loop cut the tissue between these two parts by the PATHOPHYSIOLOGY. So this is the procedure. You look the video.
Prostate, or TURP, is routinely screened for the presence of cancer. Your doctor will then lift your penis upward. A well-lubricated instrument called a resectoscope is then gently inserted into the urethra.
So there is a prostatic urethra, there is an external split here. So
when the resectoscope reaches the back of the penis, your doctor will pull the penis downward in order to create a straight path into the prostate. Once the instrument is inside the prostate, your doctor will extend a small loop of sharp-edged wire from.
So look, the resector sheath is placed here. So it is the safety guard. They cut the tissue from here to there. Don't go beyond this. So there is less chance of injury to the external sphincter.
On the end of the resectoscope. Using this tool, your doctor will then scrape excess tissue from the prostate, restoring it to its normal size. Tissue removed from the prostate may be sent to a laboratory for analysis. When the surgery is complete, your doctor will remove the resectoscope.
So the whole enlarged part of the tissues are removed. It can assess the patient can capable to void urine or not. It is very easy. After removing the resectoscope sheath, the bladder is pulled before that and make a pressure over the lower abdomen, and then you assess the flow of urine. If the flow of urine is sufficient, you can easily look at that time. It indicates that the resection is sufficient. The patient is capable to void urine. It is PRE-OPERATIVE can easily assess. By that assessing, then you assess that on ending your operation that the sufficient, there is no tissue obstruction there. This is the one of the clinical PRE-OPERATIVE confirmation that you are sufficiently remove the tissue for flow of urine.
Your doctor will probably ask you to wear a temporary Foley catheter. A Foley catheter is a narrow tube inserted through your urethra and into your bladder. The catheter is connected to a bag that is attached to your leg by a...
So look, the balloon is inflated, and normally we inflate the balloon usually 10 to 15 ml. But after doing the prostatectomy, we usually give the catheter, three-way catheter, the balloon capacity is about 30 ml. So in that cases, you can introduce the inflation with maximum 30 cc of distilled water. So if you more fluid and inflate the balloon, so make the traction causing more pressure bit over the neck, more proper hemostasis happen. So this is the difference between the two-way Foley catheter and three-way Foley catheter. So both the capacity is 30, but we usually give only 10 to 15 ml for normal individual, where needed for to only relieve retention or any other surgery for doing a catheter. Because if you more inflate the balloon, there is a more irritation of the bladder neck. For that reason, in a normal individual, whenever we do surgery, we don't inflate the balloon more. Small amount of balloon is inflated, 10 to 15 ml is sufficient. But in case of enlarged prostate, after doing surgery, the balloon needed to more inflation because it causing traction and hemostasis for that reason. And after 24 hours, the traction is relieved, the balloon is deflated also to some extent.
Strap. While the Foley catheter is in place, urine will pass from your bladder into the bag. You will not need to urinate into a toilet. The nurse will show you how to change the bag when it's full. An appointment will be made for you to return to the doctor's office in a couple of days to have the catheter removed. As soon as the anesthesia wears off and you feel comfortable, you will be allowed to leave.
So it is another video. There is two terms is there. One is TURP, another is TUVP. TURP, that means transurethral resection of the prostate. TUVP means transurethral vaporization of the prostate. That video is previous. This video is the bipolar saline TURP. That bipolar saline TURP machine having a special capability. There is a button. That button, whenever you rub over the surface, the tissue becomes vaporized and make the channel. And receptoscope, the tissue is more delineated card and less amount of bleeding. Look the comparison of the two methods. So look, this is the receptoscope sheath. By one lobe, the current is come. The other lobe, the current is go. For that reason, it is bipolar saline TURP is done. But here, one lobe is there, another lobe is there, but it is connected with a button. Whenever that button is rubbed the tissue becomes vaporized. But here, the lobe cut the tissues and move it out. This is called the resection of the prostate, and this is called the vaporization of the prostate. But the difference is, in case of vaporization, you don't able to capable to take the tissues because the tissue is vaporized. But in case of resection, you are capable to take the tissue for histopathological examination. This is the main difference. So look at how the vaporization happened by the button TURP. This is the Olympus mechanism. Just grab the tissue becomes vaporized. So look, it is a cut the tissue with the receptoscope sheath. The median lobe is cut. Go down. So in case of vaporization, there is a less bleeding. In case of resection, there is to some extent bleeding more than the vaporization. So in case of transfusion needed, in case of vaporization, less than 1% people, there is a 4% people may needed in case of TURP patient. So this is a newer technique which is called the RESUM. The technique is transurethral water vapor therapy. Transurethral water vapor therapy. It is a new conception and very beautiful technique. In that technique, the urothelium is not cut. Only the periphery of the urothelium, the enlarged tissues become vapor by putting the needle. Look carefully, the difference between the two. All the vaporization or the previous vaporization and by the receptoscope, the urothelium is damaged up to the veru. but here the urethrum is intact. The surrounding and enlarged tissue is vaporized by putting a needle over the tissue. Look.
It's a common problem for older men, benign prostatic hyperplasia, or BPH.
BPH is a fancy way of saying the prostate is getting larger and when we don't want it to.
Dr. Toby Kohler, a Mayo Clinic urologist, says the enlarged prostate forces the urethra to narrow, causing a variety of urination problems. And as men age, the symptoms...
Look, the urethra is compressed there by the enlarged lobes, hyperplastic tissues, surroundings.
Symptoms occur more frequently. Treatment for BPH has long been medications and procedures such as lasers or an electric loop, which burn the prostate from the inside out. But now a relatively new convective water therapy treatment uses steam to make the prostate smaller.
For 9 seconds, a steam ball is produced.
Look, the needle is passed through the mucosa to the surrounding enlarged tissues. The mucosa is intact.
And that kills all that prostate tissue that we don't want or that is growing out of control.
Dr. Kohler says the procedure performed right in the doctor's office has a very low risk for complications or
only
sexual
9 seconds. Only 9 seconds vapor condense releasing thermal energy. Only 9
side
seconds.
effects.
It does not carry heat outside the prostate and it does not carry heat to areas we don't want it.
He says this next generation of BPH treatment may soon replace the need for costly medications. For the Mayo Clinic News Network, I'm Jason Howland. It's a common problem for older men.
So these are, up to that, it is a benign of the prostate. Now more than 1 hour, 40 minutes pass. So I think probably today up to that level discussion is okay. So if there are any question, now the next day we can discuss the next two topics. Day after tomorrow also discussion. So now open for question.
Hello. Hello, Assalamualaikum, sir. Give my answer to the question, types of URP.
Yeah. Types of?
Types of TURP.
Having two types of TURP. One is unipolar, monopolar, and bipolar. It is the only for the TURP, transurethral recessional prostate. But the endoscopic procedure of the aesthetic surgery, the other names are laser TURP, saline TURP. These are the others one. But the types of TURP basically is a monopolar TURP and bipolar TURP.
Thank you, sir.
Thank you. Any more question?
Sir, Assalamualaikum.
Waislam?
Sir, I have a question from the previous lecture.
Yeah.
Sir, if patient having bilateral renal or ureteric stone that is confirmed by the plain X of KFB,
yes, but
patient is known case of CKD and having creatinine is slightly higher.
Yes.
So, what should we do the further investigation and the further management protocol?
So, in that cases, we don't able to do the IVU.
Yes, sir.
So, for the assessment of the kidney function, we go for the isotope scan. If you do the dynamic isotope scan and DMS and DTPS scan, you can evaluate which kidney is more functioning and which kidney is less functioning. If the better functioning kidney treat first, then
yes,
go
sir.
for the other kidney which is less functioning. It can differentiate by doing an isotope scan. Otherwise,
yes,
you don't able to go for the IVU, so don't able to assess the function of the kidney. But in our
yes,
country, we can do the surgery by doing an plain CT urography. You can easily assess the level of obstructions, where the stone obstructed more dilated there. That means more obstruction there is a less functioning probably. Or more functioning, yes, less obstruction there is more functioning. So with that comparison, by doing a plain CT QV, we can assess that which one is more functioning, which less functioning.
Yes, sir. Thank you, sir.
Am I clear?
Yes, sir. Clear, sir. Thank you, sir.
And in the previous lecture, one thing I missed it there, the contraindication of IVU. I don't elaborate describe there. The contraindication. The contraindications are, one is any hypersensitivity of the tracts, that means IOP. You don't go for the IVU with the contrast. And another one is if the patient is multiple myeloma. Because in case of multiple myeloma, the patient, every chance of renal failure if you do the IVU, because during IVU, the patient needs to dehydrate 10 to 12 hours of fasting. So in case of multiple myeloma, the treatment protocol is advise the patient take increased amount of water. So if you make a dehydration, there is a more chance of precipitation of the myeloma protein and blockage the kidney. So that thing sometimes asking the exam. Am I clear?
Yes, sir.
Any more question? That description is more elaborately, probably all the things you don't need for the your exam, because the corona period, there is a more relaxation of the time. For that reason, you can discuss, you can learn to some extent, which may something is beneficial, helpful for your previous career life. Don't need to everybody having a surgeon, but everybody must know the renal function and treatment, because it is daily you can deal with the patient of the urinary systems. For that reason, everybody, the conception must be clear. It is not only the job for the urologist. I think it needs to everybody to clear the conceptions by reading the books, clear the queries, and seeing the videos. So you can easily memorize the things. If you do some videos in the YouTubes, you can some help and memorize easily. That is the treatment of the patient. This is the TURP, this is the TURPT, this is the IOU, that thing it is.
I have a question, sir.
Yeah.
That during TURP, can we only remove the transitional zone instead of removing the whole prostate?
Yes, because if you remove the whole prostate, so what thing happen? You remove all the prostate, so the bladder neck is disconnected from the urethra, bulbous part of the urethra. So how the patient is micturate? By endoscopic operation, you don't able to stitch from the neck to the urethra. And
Yes, sir.
the peripheral part, in case of benign anal prostate, the peripheral part usually don't hypertrophy. The only transition zone is enlarged. So if you remove the transitional zones, your purpose is over. There is more channel for passing the urine from the bladder to the urethra. So your aim to channelize the urethra, posterior part of the urethra. For that reason only we remove the transition zones. Though the transition zones is not capable by doing the TURP, it is the only the zone of transition. No. To some extent may more, if you more resection, more peripheral part also come out. So your main aim is to channelize the urethra. It is the main aim. Okay?
Yes, sir. Yes, sir. Thank you, sir.
So thank you everybody. Thank you for presence hearing. Day after tomorrow at 10 p.m. again we can discuss about the carcinoma of prostate and speech urethra. So everybody read the book and then you can easily understand what the diagnosis and how can you treat the patient and what is the treatment is. Okay, thank you. Thank you.
Assalamualaikum, sir.
Assalamualaikum, sir.
Assalamualaikum.
Assalamualaikum.